Okay, hi, it's Kevin Winthrop again. Jack, thanks for letting me talk more about what I'm seeing at ACR. If you notice, it's now Saturday and I'm still in the same coat and tie and shirt. I'm still at the same election party, still waiting for it to get over. But I was able to look at posters this morning. And I'm still waiting for some of those plenary sessions to come later today. But I saw some interesting things, particularly around COVID. Now, of course, we could talk about COVID-19 for the entire conference. We just finished ID week and spent a lot of time talking about it. And of course, it's on everyone's mind. There were some interesting posters presented this morning that I think raised some issues that we've seen in other data, and I think helps solidify an emerging consensus that the most of your patients in rheumatology are probably not at higher risk, but some are. There's probably some subsets of patients that are at higher risk for severe outcomes. This was poster 623. It was a observational study out of UC Riverside, highlighting the high mortality in those patients who had cytokine release syndrome. No surprise there necessarily. A lot of these patients were placed on tocilizumab. They didn't necessarily report outcomes associated with tocilizumab, which I think was good, frankly. I think this has been a very interesting 6 or 8 months of science in which we've seen many, many positive open label reports of not just tocilizumab or sarilumab, but other agents of other mechanisms of action. In a number of those agents, hydroxychloroquine is another good example. In most of those agents so far, when put to the test in RCT format, have failed to meet their primary endpoints. So again, Xavier Mariette and I just published an editorial in ARD. If you're interested, check it out. But we did our best about, 3 or 4 weeks ago to summarize IL-6 inhibition data to date and talk about the utility of steroids. So what about steroids? Clearly, there is the recovery data that put dexamethasone on the map. And what that data shows clearly is that if you start dexamethasone too soon, you're not going to help the patient. You might even harm them. There's a hint of that in the data. If you start it at the right time in patients who are sicker, then there seems to be a mortality benefit and a clinical benefit beyond that. And it has become the standard of care. And now we have data, of course, that was released in press release form only. So I'm waiting for the paper, but that is the use of baricitinib on top of dexamethasone, that's baricitinib on top of remdesivir. And that seemed to add a little bit of improvement on top of remdesivir alone. And now, contrary to dexamethasone, what we see with remdesivir are one true antiviral, I suppose, at this point. Again, you got to start at the right time. If you use it early, you see a benefit. If you use it late in the disease course, you're probably not going to see much benefit. And that seems to be the story we're also seeing emerging with the monoclonal antibodies against spike protein, for example. Again, if you use it early, there's some good data so far, although it's very limited in terms of its publication and what's been reported. But we do see an antiviral effect, and it seems to have some benefit. We don't really have much information yet about later stages of illness. I'll talk more about that later. But what I wanted to say too is abstract 629 jives with what's been released by the Global Alliance for Rheumatology for COVID, who's done a fantastic job. And there's a number of other registries as well. The IBD registry, the Secure IBD registry has been really useful as well, looking at TNF blockers. That data has shown, or it's just in observational fashion, the patients on TNF blockers seem to be protected from having more severe outcomes of COVID. The data presented in this abstract hearkened a bit towards that, but also highlighted the fact that patients coming in on higher doses of steroids probably have worse outcomes. Now, this poster from Madrid, 629, this was an observational study. They didn't have any sort of fancy modeling or multivariate analysis, but they did suggest patients on higher dose steroids who enter the hospital, patients who are on those doses at prior to infection are at higher risk. Now, whether that's the underlying disease talking or whether that's the steroids talking, who knows? But that does jive with the larger observational data published by the Global Alliance, which did have multivariate control and looked at a number of risk factors and did find a similar independent association. So my take on it so far is this. high dose steroids, to be on them, is bad. We already know that. It's bad for lots of reasons. Once you've got COVID, you want to start an antiviral, and that's probably remdesivir as early as you can. And you probably don't want to start any sort of more immunosuppression until later stages of illness. And that's what we're seeing so far. But this is far from settled. We got a long way to go. So far, we're hitting singles. We had a single with remdesivir, maybe a single with Barry on top of remdesivir, another single with dexamethasone. Maybe we got runners on second and third, but we need a home run. So that's what I'm hoping for. And I'll be back tomorrow to talk more about some of the other interesting findings at ACR. So have a great day. Cheers.